Хорошо. Сейчас я проверю, как ходит. Дмитрий, я прочитаю лекцию и просто отключаюсь, да? Там какое-то время ждать потом, там звонить не надо этого, да? Х- Хорошо. А завтра мне можно будет еще одну лекцию прочитать? Это у меня тут большая нагрузка по лекции на той неделе. Мне когда лучше вам позвонить? Какое время? Хорошо, конечно, потому что потом у меня занятия будут часу 50. Договорились, спасибо. Мгм. Можно начинать. Все. Спасибо, Дим. Благодарю. Мгм. Good afternoon, ladies and gentlemen. Today's lecture is number 5. Topic of the lecture is hypersensitivity reactions or allergy reactions. But here you see on the upper left part of this slide brief characteristic of 4 types of allergy reactions, or 4 types of hypersensitivity reactions, type 1, 2, 3, and 4. And below this naming of the types of hypersensitivity, you see list of immune reactions. Hypersensitivity type 1 is mediated by immunoglobulin E, specific for allergen. Hypersensitivity type 2 is the major immune mediative reaction is based, but major mediator is immunoglobulin G and immunoglobulin M. Type 3 also immunoglobulin G and immunoglobulin M. And type 4 is mediated by T helpers type 1, T helpers type 2 is less extinct, and cytotoxic T lymphocytes. You see that allergy reactions are immune responses, but in normal immune responses that's related to clinical manifestation of diseases. And different type of allergy reactions or immune responses, they're based on the involvement in the reaction of different immune factors specifically recognizing so-called allergen. And this is a foreign antigen capable of causing this exaggerated allergy reaction. One of the variety of results is shown in the photograph in the right part of the slide. You see back of the baby coated with red inflammatory zones with the pale centers and red peripheral parts. This is a so-called urticaria, atopic reaction on the skin. So, designation of hypersensitivity reactions or allergy reactions. Hypersensitivity reaction and allergy, they are synonyms. Allergy or hypersensitivity is the term used for immune responses that occur in the exaggerated or inappropriate manner. Exaggerated or inappropriate. They are pathological immune responses. Allergic or hypersensitivity reaction is given in given individual occurs in contact with of this individual with a specific antigen that is named allergen. Sensitivity reaction is very individual. Majority of people don't react to the certain substance, allergen, for cause of the disease. But some patients, immune system of that is capable of recognizing allergens in the destructive form. What even these patients develop symptoms. What in the right side of the slide you see boy with the inflammatory reaction in the left cheek. This reaction, most possible, was made by the attack of the flies, for example, get fly, or be biting of these insects, and some people cause the severe reactions, more severe than in other people. So allergen, this is an antigen capable of causing allergy reaction of a certain patient. Allergens, briefly. Allergens are ordinarily harmless substances. Chemically, they're proteins or chemical compounds bounded to the proteins. They're usually proteins shaded. So they are harmless substances, such as pollens. They're shown here 3 units of pollens in the microphotography on the left part of the slide. Also, typical allergens may be shaded to animal denders, to many types of foods, and various drugs, including penicillin. Most people don't exhibit clinical symptoms to the allergen, to the certain allergen. However, some individuals respond to these substances by producing large amounts of specific mediators of the inflammation, such as the immunoglobulin E, for example, and as a result, they manifest allergy symptoms. If do they have increased amounts of immunoglobulin E, can reacting to the allergen, for example, to the drug named penicillin. In the left part of the slide, you see 3 units of pollens of vegetation that is named Regbit ambrosia, the ambrosia pollens. Ambrosia pollens is one of the most common causes of the summer hay fever in patients. In the complicated cases, they may cause severe dysfunction of respiratory system that is named asthma, anaphylactic asthma. You see in this slide that there are many typical variants of the allergens that different people may cause allergy reactions. Now you see that many sea products serve as allergens. Some shellfish, crabs, shrimps, some soybeans, nuts of different origin, eggs, milk and milk products, many vegetatives, some types of fish, and so on. It means possibility to develop allergy in different people. This possibility worldwide is very high because many absolutely different things may cause allergy reactions in people who respond normally to the consuming or contact to these things. There are many trees that are known as typical allergens. Among them, juniper, elder, ash, elm tree, oak tree, maple. What oak tree is a typical cause of the skin inflammatory diseases, so allergic dermatitis. What about characteristic of the basis of the hypersensitivity reactions and what is common in hypersensitivity reactions that are caused by absolutely different allergens? All hypersensitivity reactions are secondary immune responses. Secondary, it means clinical manifestations are not seen in the first contact of the person to the allergen. What you see some small people shown here. What person number 1, this is not the one, this is same person in all the stages. What one? When first inoculation of allergen is happened, what here you see syringe with the pink allergen, this person doesn't react clinically because first contact to the allergen is not the secondary. It means only after inoculation of allergen to the individual, sensitive individual, this individual during a certain time develop immune response. Immune response causes accumulation in the patient's organism of the immune factors that will recognize allergen inoculated repeatedly. It means what person number 2 here doesn't react pathologically to the allergen because doesn't have contact with this allergen. But person number 2 is sensitized. It means this person has immune factors that are ready to respond to the allergen if this allergen would be inoculated, will have a contact with this person repeatedly. With this situation, when allergen contacts, when person or this person is exposed to the allergen repeatedly, is shown in the stage of this development of this process number 3. We see that clinically healthy person is exposed to the allergen again. This would be secondary contact with the allergen. And secondary immunization, it means secondary contact with this allergen, causes reaction between new portion of allergen and between immune factors that were accumulated and deposited in tissues of this patient before, after first contact with the allergen. Result is shown by the number 4. Number 4 demonstrates that this smiling person becomes very sick, and here you see that person that maybe have unconsciousness. This is a typical for anaphylactic shock. Anaphylactic shock. This is a most dangerous manifestation, clinical manifestation of the allergy that may cause quick death during minutes. So, allergy reactions are the secondary immune responses to the familiar of the same allergen. Allergen, this is an antigen, specifically causing this reaction. So, secondary response in individuals who have been previously sensitized, with number 1, to the allergen during the first contact with the allergen. So, the first dose of allergen causing sensitization. So, sensitization is a state of the person marked by the number 2 and 3. The first dose of allergen causing sensitization, this is a development of the possibility to react in the exaggerated form. And sensitization, for example, may be demonstrated by production of immunoglobulins E specific for the allergen. The first dose is known as a sensitizing dose, and this is a comparatively high dose, or sensitizing or priming dose. This dose can be fairly high and cause no visible symptoms of the disease. It means high dose is manipulated to avoid the first stage, to the same boy with person in the second stage. But second stage reflects that this is a sensitized person because he have immunoglobulin E specifically reacting to this antigen. The subsequent contact, situation number 3, of the individual with the allergen, is elicit the allergic response. The dose causing is known as the shocking dose. The second shocking dose, this is a dose that of allergen causes development of symptoms. This shocking dose causes visible symptoms. What situation number 4? It can be very small, much smaller than what first sensitization dose or sensitizing dose. There are a variety of different allergy reactions and diseases based on the development of allergy reactions. Most the most known maybe classification of allergy reactions is Gilles and Coombs classification, or Coombs and Gilles classification of allergy. These classifications subdivides all the allergy reaction into 4 types: 1, 2, 3, and 4. It means hypersensitivity type 1 on the left, hypersensitivity type 2 near to this left, hypersensitivity type 3 the next, and the hypersensitivity type 4 is shown on the right part of this slide. You see that hypersensitivity type 1, 2, and 3 that are named compared to the anaphylaxis, cytotoxic, and immune complex hypersensitivity. But these 3 forms, they have a common characteristic. They are all these 3 named immediate type of hypersensitivity reactions. Immediate type. It means after nucleating shocking dose of allergen, clinical manifestations are developed during minutes or hours, very quickly. So, what these first 3 hypersensitivity reactions are mediated by presence of immunoglobulins, so antibodies specific to the allergen. First type, or anaphylactic hypersensitivity reaction, see on the left part of the slide, is based on the correlation of the human body of such mediators of the allergy as immunoglobulin E. Immunoglobulin E is a very low concentrated antibody in the human organism, and increasing of this presence of this immunoglobulin up to that 2 or 10 times usually is evidence of the allergy type 1. Immunoglobulin E, this is a cell, this is a humoral mediator of hypersensitivity. Among cells involved, very important role of the mast cell and basophil. Why? Because mast cells, basophils, and eosinophils also, they have on the surface of the membranes Fc epsilon receptors. They are receptors that strongly bind immunoglobulin E and absorb this immunoglobulin on the surface of mast cells and other cells that have this type of receptors. So, what these immunoglobulins E absorb to the surface of mast cells serve as the antigen receptors of these mast cells. Mast cells recognize presence of specific allergen via contact with the far fragments of the immunoglobulins E situated on the surface of the mast cells. If allergen, that is shown here by the green star, enters to the human body of the sensitized person, this allergen, first of all, this allergen must be polyvalent, having many, at least 2 or more allergen determinants. This allergen binds to the neighboring immunoglobulins E situated on the surface of the mast cell. This reaction of the allergen to the antibodies, membrane-associated immunoglobulins E, causes cross-linking of antibodies and correspondingly cross-linking of the Fc receptors of the mast cell to these antibodies. This cross-linking generates signal for activation of mast cells and releasing of content of the vesicles, so-called granules of mast cells, to the extracellular space. Content of these granules, content that is released outside of the cells, contains many biologically active substances, and first of all, histamine. Histamine causes change in the vascular permeability, increase in the vascular permeability, increase of the, so causes relaxation of smooth muscle of the vessels. But the contrast, histamine causes contraction of the muscles of the respiratory system, of the bronchi, and this causes problems with the breathing. Increase in vascular permeability, swelling of the vessels may cause fall of the blood pressure. If this blood pressure fall is high, this may cause anaphylactic shock. Anaphylactic means belonging to the type 1 and associated to immunoglobulin E and mast cell degranulation with the release of histamine. Anaphylactic type 1 hypersensitivity reaction is most quick and dangerous because may cause anaphylactic shock, and you must remember what you have to do. First of all, if patient has this allergy and you see development of symptoms of this allergy, you have to inject to this patient adrenaline or epinephrine that act as the antagonists of the histamine. Second, hypersensitivity type 1, that also is named cytotoxic, has a different mechanism because mediators of this hypersensitivity reaction are immunoglobulins G and immunoglobulins M, not the E, as in the first type hypersensitivity, but immunoglobulin G and immunoglobulin M. What is happening in the hypersensitivity type 2? Immune reaction causes destroying and lysis of target cells that are human body cells. It means this allergy causes binding of the immunoglobulin G or immunoglobulin M, specific for allergen, to the surface of target cells. In this slide, allergens are shown by the green triangles that cover surface of target cells. Now, these target cells may be red blood cells, maybe platelets, maybe epithelial cells, maybe thyroid gland cells of thyroid gland. So different cells may be attacked and destroyed as the target cells. What are the mechanisms of this destroying? First of them is attack of the natural killer to the target cell, because natural killer cell has receptors for immunoglobulins M and immunoglobulins G, and if these target cells have the surface allergen that binds to the immunoglobulin specific to this allergen, natural killer cell recognizes this immunoglobulin as a molecule that initiates signal for attack. A natural killer cell binds to the target cell, releases enzymes and perforins. They are shown by the yellow circles and blue squares, and these cytocidal substances attacks membranes of target cell, causing lysis of this cell. One, this process of destroying of the target cell by natural killer with the help of the antibodies is named antibody-dependent cellular cytotoxicity, ADCC, antibody-dependent cellular cytotoxicity. Antibody-dependent, it means antibody serve the instrument to find target cell. Cellular cytotoxicity means that cytotoxic effect, means killing of the target cell, is caused by cell, in our case, natural killer cell. First mechanism of killing. Second mechanism of killing of their own cells that contain allergens on the surface. This activation of complement. Now we understand that is immunoglobulin G or M bind to the allergen on the surface of target cell. Antigen antibody complex is formed. This is the triggering mechanism for activation of complement system by the classical pathway. Complement molecules are shown here as the red triangles. Complement during the activation forms a membranous complex that's not shown here, but you know that this is a pathological pore penetrating membrane of target cell, and the target cell dies after this. In this square is not shown third mechanism of killing when target cell is attacked by the macrophages that also have Fc receptors for immunoglobulin G. And macrophages may engulf target cells, causing death of this cell. This effect would be named as the opsonization. This is a cytotoxic type 2 hypersensitivity. The next, on the right, this is a type 3 hypersensitivity type 3 that is also named immune complex hypersensitivity. What is happening in this allergy? This allergy is developed if in the bloodstream circulate long time circulates that antigen, enough long time. Antigen here, or allergen is shown by the with these green ovals, the green ovals. This allergen binds to the antibody that also circulates in the blood. These antibodies cause something similar to the precipitation in the human tissues, because form complexes consisting of not 4 molecules of allergen or 4 molecules of antibodies shown here, but from the hundreds and thousands of the antibody molecules and allergen molecules. These complexes may be large in size, intermediate size, or small. Most dangerous are intermediate size complexes, immune complexes that migrate in the blood easily. Very large complexes, they are deposited in the place of the formation. Our intermediate size may migrate. These migrating complexes may be sedimented on the surface of the endothelial cells of the vessels. In some cases, if allergen occurs in the extravascular space, these complexes are formed outside of the vessels. But in any case, they are deposited on the surface of the endothelial line of the vessels. Immune complexes, they're immune complexes. Immunoglobulin G contain or immunoglobulin M. They activate complement system. But here you see C3b fragments as the molecules of the activated C3 component of the complement system. And complement system forms the chemoattractants. These chemoattractants generate signals, chemical signals for neutrophils and monocytes and macrophages migrating in the vessels. And these immune cells becomes recruited and moved to the place where this inflammatory reaction is developed, where immune complex is present. These phagocytes try to destroy immune complexes. They try to engulf them, and at the same time try to solubilize elements of immune complexes, releasing toxic compounds from the leukocytes to the immune complexes. Now, what are these compounds released by neutrophils and macrophages? First of all, the reactive oxygen species, such as the hypochlorite radicals, nitric oxide, and other oxygen-containing substances. These substances destroy not only immune complexes, but neighboring human cells, including endothelial cells. Endothelial cells becomes destroyed, and vessels damaged. This damaging of the vessels may cause many symptoms of allergy reaction. For example, if vessels of kidneys are damaged, glomerular nephritis may be developed with the damaging of the kidney tissues, with the appearance of the protein in the urine, or hemoglobin in the urine. Another process in the joints may cause arthritis if in vessels of joints these processes happen. And due to the immune complex nature initiation by reaction of immune complexes, all the reaction was be named immune complex allergy. It means anaphylactic reaction, cytotoxic reaction, and immune complex reaction. There are three types that are based on the appearance in the human body of the allergen-specific immunoglobulins of different types. All these reactions after inoculation of the allergen, second repeated inoculation, demonstrate symptoms of disease during minutes and hours. And due to this, first, second, and third allergy were subclassified as the immediate type hypersensitivity. It means immediate, very quickly develop clinical reactions after repeating inoculation of allergen to the organs of the sensitized to the allergen individual. In the contrast, the last type of hypersensitivity, what's shown by the yellow cell and yellow title, is characterized as a delayed type hypersensitivity or cell-mediated hypersensitivity reaction, or hypersensitivity reaction type 4. Antibodies are not required to develop this hypersensitivity. This hypersensitivity based on the accumulation in the patient's tissues of the T helpers type 1 cells, specifically reacting to the allergen. In this scheme, you don't see antigen-presenting cell digesting and processing and presenting antigen. Instead of the cell, painter draw only 3 green ovals. But you understand that T helper cell can directly recognize allergen if allergen is not presented by antigen-presenting cell. If we'll put here on the top of this antigen-presenting cell, all the scheme of reaction would be look like correct. So, if in the patient's organism many T helper 1 cells, they also are named as a delay type hypersensitivity cells, DTH cell, DTH. These cells react to the allergen presented by macrophages or dendritic cells. T helpers type 1 release cytokines, first of all interferon gamma and tumor necrosis factor, alpha and beta. And these compounds hyperactivate macrophages. You know that macrophages may be subclassified in 2 forms: M1 macrophage, inflammatory cell, and M2 macrophage. M2 causes downregulation of inflammatory reaction and initiation of the reparation of tissues. T helpers type 1 involved in the delayed type hypersensitivity, of course, activate M1 macrophages. M1 macrophages activated by interferon gamma start presenting increased amounts of the receptors on the surface, such as the MHC2 receptors, what here you see 4 receptors of this type. Increase of the synthesis is explained and exposing on the surface of the other receptors, for example, mannose receptors for pumps of some microbes. And M1 macrophages increase very intensively synthesis of the oxygen species, reactive oxygen species, H2O2, hydroxyl radicals, nitric oxide, hypochlorite radicals. They accumulate in the granules, vesicles of macrophages, in the lysosome of macrophages. They are used for more intensive digestion of the microbes that contain allergens or other substances. And additionally, these reactive oxygen species are secreted by macrophages to the extracellular space, and you understand that side of the substances may destroy many substances, including cells that are situated near to the macrophages. Additionally, macrophages release to the environment, microenvironment, many types of enzymes. They are proteases, DNases, lipases, catepsin, and many others that are lytic for different proteinaceous substances that also cause the effect of destroying of the neighboring cells surrounding macrophage type 1 activated. So what macrophages are attracted to the places where allergen is accumulated by the cytokines of T helper type 1. T helper type 1 also recruited and accumulate in this area. So this area becomes infiltrated by T helper type 1 and hyperactivated macrophages. Also, cytotoxic T lymphocytes are recruited in this area, or they also are involved with the damaging of the cells that are present in this infected area. As a result, tissues where this helper type 1 and macrophages type 1 are accumulated becomes damaged, destroyed. Own cells are destroyed, allergens are destroyed, and these places accumulated products of the destroying. What classical disease that has this pathogenesis based on this hypersensitivity action type 4 is the tuberculosis. And you know that this lung disease is characterized clinically by formation of the holes in the lungs that are named caverna. Caverna is formed in the part of the lung where own tissue is destroyed and coughed out through the respiratory system. What damaging of lung tissues, this is direct effect of the hyperactivation of macrophages. So in the maturation of monocytes recruited from the vessels to the macrophages type 1, that cause all these destructive effects. Of course, because many types of cells must accumulate in the area of organism where allergen is present, or this attraction, migration, movement, and accumulation in the infected place requires the time, days. Usually 3 or 4 days are required to generate inflammatory reaction after contact to the allergen. And due to this, reaction is delayed because requires 40, 50, 60, 70 hours to be developed. In the contrast, anaphylactic reaction requires minutes, 5, 6, 10 minutes to cause severe inflammatory reaction after the anaphylactic shock if this is a systemic disease. Now begin from this slide, major part of the lecture I'll spend to explain problems of the hypersensitivity type 1 that is named anaphylaxis. First stage of the immunopathogenesis of the anaphylactic allergy type 1 is development of the sensitization. What left part of the slide, marked by the yellow arrow and the yellow label, number 1, is the sensitization stage. What is happening? Allergen enters the human body. Allergen presenting cell, what here dendritic cell is shown, engulf this antigen, processes this antigen, and this is allergen. Of course, you understand allergen. And present this allergen in the complex to the MHC2, MHC class 2 molecule on the surface to the T helper cell. What T helper cell has T cell receptors. If these receptors specifically react to the presented antigen, this naive CD4 T helper cell, what spherical blue cell, replicates, produces progeny, and this progeny is undergone to the polarization. It means progeny cells are polarized or are converted to the T helpers type 2. T helpers type 2. These helpers, actively secrete interleukin 4, interleukin 5, interleukin 13. This secretion activates B lymphocytes that also specifically recognize allergy. Not all, but all the B lymphocytes specifically recognize this allergy. These B lymphocytes start their proliferation, and majority of them are transformed to the progeny cells are transformed to the plasma cells producing immunoglobulin E. Synthesis of immunoglobulin E is maintained by synthesis of interleukin 4 by T helper type 2 cells and some other cells, for example, by the activated mice cells. What is important? That in the microenvironment where all these cells are present in the lymphoid organs, signal from cytokines from interleukin 4 stimulates synthesis of immunoglobulin E. Immunoglobulin E comes to the blood circulation, and through the blood circulation is distributed, spread in the human body, and these immunoglobulins find the Fc epsilon receptors of mast cells, analogous receptors of basophils, analogous receptors of the eosinophils, and on the surface of all these cells appear membrane-bounded immunoglobulins E specific to the allergen. So, what presence of these sensitized mast cells and basophils that have on the surface antigen receptors in the form of globulin E, or even this situation is named sensitization. It means our patient has the sensitized mast cells that may react if allergen will appear repeatedly in the body of this patient. In the blood of this patient circulates immunoglobulin E. What has happened after that? What right part of this figure demonstrates, what right part marked by the number 2 demonstrates what has happened after re-exposure of this patient to the same allergen. Allergen, of course, again, engulfed by the macrophages dendritic cells, by antigen presenting cells. No, what this first side is not required. So we understand what in the human body, in the case of re-exposure of allergen, occur what mast cells and eosinophils and basophils carry on the surface of globulins E. But allergen molecules bind to this immunoglobulin E associated to the membranes of these cells and cause so-called cross-linking of immunoglobulins E on the surface of the mast cells and basophils. Cross-linking, it means a polyvalent allergen binds simultaneously to at least 2 neighboring immunoglobulins E. This is a cross-linking of immunoglobulins through the contact of the same allergen molecule. As a result, cross-linking is happened with the Fc receptors. But Fc epsilon receptors, when are cross-linked, they generate signal that causes degranulation. It means release from the granules of the mast cells of the histamine and other inflammatory substances. Histamine is released later, 3, 4, 5 hours later. Leukotrienes, platelet activating factors, serotonin, and many other inflammatory substances. For example, histamine causes relaxation of the smooth muscles of the vessels. Capillary and postcapillary veins are relaxed. In these vessels accumulate more blood than before. If this process is present in all the human organism of the patient, with this accumulation of blood in these swelled open vessels causing fall of the blood pressure, if this is enough high fall of the blood pressure and enough long, that lasts for not the seconds but minutes, shock may be developed. If shock has for this pathogenesis, shock would be named anaphylactic shock. Anaphylactic shock may be caused by the injection of drugs, if these drugs are allergens for the person, or by the biting of the bears or gadflies, or by the eating of the food that consists of the allergenic compounds. So it means re-exposure causes for this early allergic response that is mediated by the substances released from the mast cells and basophils as a result of contact with the allergen of the immunoglobulin E molecules on the surface. You see in this scheme that cells involved are mast cells, basophils, and later eosinophils. During the exposure to the allergen, many pro-inflammatory mediators are released. And cytokines maintain this release of the pro-inflammatory mediators. What are these mediators? They are histamine leukotriene activating factors, and some other. And on the level of cytokines, pro-inflammatory compounds are interleukin 5 and 4, interleukin 3, interleukin 13. What interleukin 4 and 13 are produced by T helpers type 2. Interleukin 4 and 5 also may be secreted by mast cells, activated during degranulation. Interleukin 4 and may be released by eosinophil, and eosinophil additionally produces such pro-inflammatory cytokines as the basic proteins, also leukotrienes, platelet activating factors, but substances produced by eosinophils, and some of them are produced by basophils. In this slide, you see alternative scheme of the immunopathogenesis of anaphylaxis. The process, what you see, and I hope that you now can recognize the most important details. Now, first of all, in the first exposure of the patient to the allergen, antigen-presenting cell presents this allergen to the CD4 T helper cells. In this scheme, we see that cell that reacts to this presented allergen is naive Th0 cell. This cell proliferates and produces massive progeny. Major part of this progeny are mature to the T helpers type 2, or this purple cell in the center. You see that arrow shown here is larger than other arrows, but exception for this type of the polarization of T helper, it means polarization, it means maturation of a certain type of the immunocompetent cell, in our case of T helper type 2 cells. Naive T cells may be additionally be mature to the T helpers 17, T helpers type 1, and the T regulatory helpers. It means what additional helpers may occur, may be important. But most important, of course, is T helper type 2. T helper type 2 secretes interleukin 4, interleukin 5, interleukin 13. And via this secretion, T helper type 2 cells activate B cells for transformation to the plasma cell that will produce huge amounts of immunoglobulin E, the mediator of the allergy reaction. In this class, switching of immunoglobulins from the immunoglobulin M and G to the synthesis of immunoglobulin E, very important role is of the interleukin 4. You know that immunoglobulin E absorbs to the mast cells, basophils and eosinophils, and during the repeating contact of the allergen, cross-linking of the immunoglobulins E in the surface of the mast cells is happen when polyvalent molecules of the polyvalent allergen react to two and more number of the neighboring immunoglobulin E, and allergen causes cross-linking of these immunoglobulins E. At the same time, cross-linking of the Fc receptor also is happening, and this generates activation of signaling pathway that causes degranulation of mast cells with the release from mast cells of the biologically active substances, histamine, cysteine, leukotrienes, prostaglandins, and variety of cytokines, interleukin 4, 5, 16 tumor necrosis factors. All these substances are released from the activated mast cells. Histamine and other pro-inflammatory cytokines cause swelling of blood vessels that may cause anaphylactic shock, contraction of the smooth muscles of the organs of intestinal tract and of the uterus. This may cause diarrhea, abdominal pain. When saying about influence of release of histamine and other cytokines to the respiratory system, smooth muscles of the bronchi, trachea causes contraction of the airways. Synthesis of mucus is increased, and all these things cause appearance of the attractants for eosinophils. So what about eosinophils? Interleukin 5 produced by T helper type 2, interleukin 5, causes increasing of the proliferation of the precursors of eosinophils, enhancement of the maturation of eosinophils from this precursor, and coming of the eosinophils transport to the bloodstream. Through the bloodstream, these eosinophils are attracted to the organs where actively regulation of mast cells is happening. Eosinophil is a cell that is in active form, releases basic proteins, cysteine, leukotrienes, cytokines such as the interleukin 16, eosinophil peroxidase that increasing synthesis of hyperbromic and hyperbromic acid that has a very high potential for lysis of the cells, and eosinophils accumulate in the organs where mast cells are degranulated. Cytocidal substance of eosinophils may destroy epithelial cells and other cells that are present in these tissues, causing damaging of tissue, for example, damaging of the epithelial line of the airways. Additionally, eosinophils play a role of the cells that consume histamine, free histamine that not bounded to the histamine receptors. It means this free histamine is removed by eosinophils. What about other cells? T helper 17 has a role that is lower than the role of the T helpers type 2, but they produce interleukin 17 and interleukin 22, that recruited, mobilized, and attack to this place of the neutrophils that also may appear in the zone of inflammation. The certain role play in T helper cell, the type 1. These cells produce interferon gamma that activate macrophages in the zone that contains mast cells and degranulation, and additionally increase inflammatory reaction in the affected zone of human organism. Later, naive T helper cells becomes transformed to the T regulatory cells that produce interleukin 10 and transforming growth factor beta that serve as the inhibitors of the polarization of naive cells to the T helper type 2, to T helper type 1, and helper type 17. In this way, T regulatory cells cause the downregulation of interleukin 4, 3, and 5, downregulation of the eosinophil influx to the blood and accumulation in the inflamed zone, and these T regulatory cells causing the role of the inhibitors of the anaphylactic reaction. This will be happen later when most of the pro-inflammatory substances produced by mast cells and eosinophils would be stopped to produce, the intensification would be lowered, and in this downregulation is important role of the T regulatory cells. This role must be evaluated in the treatment of the disease based on anaphylactic reactions. There are two phases of the anaphylactic reaction, clinical phases and pathogenetic phases. First is the immediate phase of the anaphylaxis. This phase is characterized by a release of the preformed mediators of inflammation, histamine, eosinophil, hematoactive factors, and serotonin, platelet activated factors. All these things are released from the granules of the mast cells immediately. Symptoms of this immediate phase of anaphylaxis. Symptoms appear rapidly during minutes. Due to this, anaphylaxis is classified as the immediate type hypersensitivity. So, what the symptoms are? Edema, erythema, redness, so-called wheal and flare syndrome, itching of the skin and mucous glands, hypertension in case of the systemic vasodilation that may finally be developed with anaphylactic shock, and wheezing due to the contraction of airways. After immediate phase that lasts 30-40 minutes, or maybe 1 hour, but initiates 2 or 3 minutes after re-exposure to the allergen, the second delayed phase is named late phase. This phase is developed about 6 hours later after degranulation of mast cells or exposure to the antigen. This phase is maintained by the pro-inflammatory cytokines that are synthesized in the mast cells and basophils after mast cell degranulation. It means this phase, late phase, is maintained by the newly synthesized pro-inflammatory cytokines that are produced by mast cells after release of histamine. Among these late phase mediators of inflammation are leukotrienes, for example, slow reacting substance of anaphylaxis. One product of leukotriene origin is named slow reacting substance of anaphylaxis, SRSA. Slow, it means slow. It means that appears later. Prostaglandins and tabaxans also are released. Symptoms of this late phase: erythema, dyspnea, induration of tissues, wheezing, and tachypnea. Now, but here you see what is happened the process of immediate phase. You see mast cell degranulating content of the vesicles. No, degranulation releases content of vessels. First of all, the histamine leukotrienes, prostaglandins, tabaxans. No histamine immediately, other with a delayed time. And what is happening to the result? Smooth muscle relaxation of the muscle vessels, relaxation of small blood vessels, contraction of the airways, bronchi and bronchioli, increasing of the mucus production, blood platelets aggregation and activation with the release of the pro-inflammatory substance of the platelets, irritation of sensory nerve endings happen, and of course activation of eosinophil with the influx of eosinophils in the inflamed area where histamine and other products of the mast cells are accumulated. Most severe life-threatening form of the type I hypersensitivity is associated to drop of the blood pressure and the severe bronchoconstriction. This is the symptoms of the anaphylactic shock. Symptoms mean with the itching of the scalp, initial symptoms, and tongue pressure, unconsciousness, kidney failure, heart failure, and risk of the death. Prompt treatment of anaphylactic shock must be with the adrenaline, that is also is named as the epinephrine. Epinephrine, adrenaline, they are synonyms. Administration, injection of adrenaline may be life-saving. People with insectine allergy carry anaphylactic kits, and they carry them over time in their life. These anaphylactic kits for emergency use contain syringes loaded with epinephrine and antihistamine drugs. What about epinephrine? Dosage in these syringes may vary from 0.1 milligram to 1 milligram per milliliter of the epinephrine. Usually, this dosage is 0.1, 0.15 milligram, or 0.3 milligram. 0.3 milligram is the most common dose that is injected to prevent development of the anaphylactic shock. Clinical manifestation: atopy. Atopic reaction, referring to the hereditary tendency to develop immediate allergy reaction as asthma, allergic skin disease, atopic dermatitis, or hay fever. Atopic reactions are caused by the antibody in the skin and sometimes the bloodstream. It means skin disease, skin inflammation, that means urticaria hives, and is seen as the itchy rashes with the clear-cut margins. But this urticaria is associated mostly by the accumulation of the sensitized mast cells in the skin. Antibody in the skin means antibodies that occur on the surface of the mast cells and basophils. Atopy, this term, means out of place, refers to localized anaphylactic reactions that may be localized in different organs of the human body, not only in the skin. In some people, they're localized in the skin, in other people, in the airways, causing asthma. Some third variant where diarrhea is prevalent when these mast cells synthesized by immunoglobulin E occur in the submucous tissues of the intestinal tract. Atomy means out of place. In different people, symptoms may be different. Localization of inflammatory process may be different. Now here you see 3 photographs demonstrating all this itchy, the margins, foci of the inflammation. This is a hives or urticaria. One of the very common clinical form of the skin atopic reaction is the infantile atopic dermatitis. Usually inflamed skin is present on the face, most of all the knees and elbows. As the person grows older, the rash usually seems to shrink and become limited to certain parts of the body. The sides of the neck and face, especially eyelids, often are affected, and the skin becomes dry, itchy, thickened, and leathery. In some cases, eczema causes the appearance of the secondary bacterial and fungal infections. And allergy reaction is combined with the reaction for these invaders, for the pathogens. And in some people, this eczema may be very, very severe and cause even death of patients. One of the important symptoms that you have to know is named Quincke's edema, Quincke's syndrome, or angioedema. Angioedema is the rapid swelling of dermis, subcutaneous tissues, mucous, and submucous tissues. In some cases, submucous tissue swelling may cause airway obstruction and suffocation that may cause death, this suffocation from asphyxia. Cases where angioedema progresses rapidly should be treated as a medical emergency as airway obstruction using epinephrine. We talked about this. Epinephrine is a substance medical emergency in case of the development of the anaphylactic reaction, and one of the very dangerous forms of this reaction is angioedema involving airways of the patient. Diagnosis of the anaphylactic reaction usually associated to in vivo tests or in vitro tests. One of the most common diagnostic tests is available in the world is skin prick test. Skin prick test shown here. This is a cutaneous anaphylaxis that is useful in testing for hypersensitivity and identifying the allergen responsible for atopic disease in the patient, for demonstration of the effect of the disease and of the causing allergen. How is performed? On the surface of the arms, usually many pricks develop, and these intradermal injections are made by the portions of the very small portions of the allergens, known allergens. When a small shocking dose of the antigen is administered intradermally to the sensitive host, was part of the photograph A, there will be a local will and flare response that is developed within 30 minutes. You see this what in the part of the figure B. Swelling of tissues demonstrates this positive reaction, but what is the negative characteristic of the skin prick test and other in vivo tests? In some individuals, skin test may lead to serious and even fatal reactions. It means very independently very small dose of the intradermal injection. In some patients, hypersensitivity is very, very highly developed, but may what will shade to development of very severe complications. Due to this, in some cases, allergy patch test is performed, and this patch test is not shaded to the injecting of the allergen, but shaded to applying of the allergen on the surface of the skin. Patch testing is a process to detect allergic contact dermatitis to something a person has contracted. If involves applying patches with these substances in small discs or chambers to a person's back. The patches are secured with hyperallergic tapes, and no needle pricking is involved. What in the left part of the slide you see how these chambers or discs are fixed to the surface, stick to the surface of the skin on the back of patient. In the right part of this slide, you see, first of all, pay attention to the histamine. What chamber with the histamine was attached to with this upper part of the back of this baby, and you see very intense inflammatory reaction. Below we see places where many other allergens were had a contact to the skin. We see that maybe one of the most important reactions is reaction for eggs, what in the left upper part of the skin, and the peanut in the left lowest parts of the skin. You see that real and free reactions for eggs and peanut is similar to reaction to the histamine. It means that what in this baby, what's peanut and eggs, what's maybe qualified as the allergens causing disease. Of course, in vivo tests have the limitation. Due to this, in vitro tests are considered more safe and better for the patients. What in vivo test for type 1 hypersensitivity, one of these tests is radioallergosorbent test that now may be replaced in some countries by ELISA, enzyme link immunosorbent assay. Idea of both these tests is the same. Radioimmunosorbent test or ELISA permits identification of specific immunoglobulin E in the serum of the patients because reaction of this immunoglobulin E to the allergen is detected. Usually 96 polystyrol plastic plates, flat bottom plates, are taken to perform this test. A solid phase coated with the test allergen, coated with the blue molecules of allergen, is inoculated with the patient serum. Patient serum contains immunoglobulin E, may contain these immunoglobulins shown as the object stained pink. The allergen absorbed to the walls and the bottom of this plastic plate combines with the specific globulin E if this immunoglobulin present in patient's blood in the serum. After washing out of the unbounded components of the reaction, the carrier plastic surface is incubated with the radio-labeled anti-immunoglobulin antibodies of a brown color. Radio-labeled, it means that immunoglobulins, anti-human radio-labeled immunoglobulins, it means any immunoglobulin specific to immunoglobulin E of people, are labeled by the radioactive isotope, for example, iodine isotope emitting gamma rays. After washing, the residual radioactivity from the gamma rays of the carrier is the plastic, is measured. This is very, very highly sensitive method. Prevention of the anaphylaxis. Prevention of anaphylaxis consists of many possible manipulations. First of all, this avoidance of contact with the potential allergen before sensitization. But this principle is often impractical. Second point, avoidance of contact with the allergen, known allergen, after sensitization. No using of the skin prick test or radioimmunoassay or ELISA for detection of allergen or immunoglobulin E. Third, this is a manipulation that named acute desensitization. Acute desensitization. Acute desensitization is the administration of a very small amounts of allergen at 15 minutes intervals to prevent large amounts of mediators to be suddenly released. It means all the dose of the allergen that you have to inject to the patient is subcutted for many small portions, and they're injected at the 50 minutes intervals. Allergen immunoglobulin E complex formed on a small scale in this case. Therefore, no major reaction occurs because not enough mediators is released. Acute desensitization permits administration of allergen to the hypersensitized persons. Treatment. The treatment of reaction includes drugs to counteract the action of mediators, antihistamine drugs, maintenance of the airways, and support of respiratory and cardiac function. Counteraction to the action of mediators consists of prevention of systemic vasodilation using adrenaline. We talked about this. A second is use of the mast cell stabilizing substances. Mast cell stabilization may be performed by inhalant isoprenaline and cromolyn sodium administration. These substances, isoprenaline for example, bind to the different receptors on the mast cell surface and make it resistant to triggering and degranulation. It means isoprenaline and cromolyn sodium may stabilize the surface of the mast cell and basophils, preventing them from releasing of the histamine to the environment. Third principle of counteracting to the activation of mediators. This is a reduction of the effects of histamine by administration of antihistamine drugs. Examples of them: Claritin, Zyrtec, Allegra, Dimiderol, for example, and many other substances that may be taken. These substances reduce such effects of the histamine as the itching, breathing trouble, and increased heartbeat. The fourth line of the drugs are steroids. They are inhibitors of late phase the anaphylactic reaction because steroids, for example, prednisolone, may prevent the release of the leukotrienes prostaglandins. Exception for steroid anti-inflammatory drugs may be taken non-steroid anti-inflammatory drugs, for example, indomethacin, cetirizine, cyclosporin A. And finally, fifth principle is use of the monoclonal anti-immunoglobulin antibodies, so-called amalizumab. These monoclonal antibodies are specifically directed to the mast cell binding sites of the immunoglobulin E, to the Fc receptors of immunoglobulin E. As a result, this immunoglobulin can bind to the mast cells. Treatment of anaphylactic diseases may be performed in the form of the so-called chronic desensitization. You remember that acute desensitization, this is a method of the prevention of anaphylactic shock, of the prevention. But chronic desensitization, this is a long-lasting analog of the first manipulation, is the method of the treatment of the disease. Chronic desensitization involves a long-term repeated weekly administration of the repeated weekly administration of the allergen to the hypersensitized people. Chronic desensitization stimulates the production of alternative types of the immunoglobulins specific for allergen, of the immunoglobulin G, first of all. And this immunoglobulin G serves as a blocking antibody that binds to the allergen, preventing contact with allergen to the immunoglobulin E. But in the left part of the slide, you see the so-called normal development of anaphylaxis with the attachment of the immunoglobulin E to the mast cells. In the right part, you see chronic desensitization, when to the patient's organism are injected repeated, rather small, rather large portions of the allergen that is administered together with the anti-inflammatory substance, antihistamine drugs, maybe steroid hormones. What are the idea? This allergen that for a long time present in the human body reacts to all immunoglobulins E synthesized before. After that, allergen circulates in the human body in the free form, and in this free form may stimulate synthesis of alternative immunoglobulin G that usually is much more concentrated than immunoglobulin E. And immunoglobulin G antibodies intercept allergen, preventing contact of allergen to the immunoglobulin E. So, finish saying about anaphylaxis. Second type of the hypersensitivity reaction is named antibody-dependent cytotoxic hypersensitivity, or hypersensitivity type 2, or cytotoxic hypersensitivity, or cell-mediated hypersensitivity, or complement-mediated cytotoxicity. What do you see? You see here two figures. On the right figure, the right up part of the slide, you see allergen-bearing target cell. This is a red blood cell. In the left side, in the left drawing, you also see red blood cell that serves as a target cell. Immunoglobulin M and immunoglobulin G antibodies are induced by allergens in the primary immune response. In the primary response, these antibodies appear. Allergens that is injected repeatedly bind with the cell surface and then contribute with allergen binds to the cell surface of the allergen bearing target cells, and antibody immunoglobulin M and G bind to this allergen that before was associated to surface of target cell. But you see these green antibodies in the left drawing when red blood cell having allergens becomes coated by the immunoglobulin G or M antibodies. And this situation is drawn in the right drawing also when immunoglobulin G also binds to the surface of a red blood cell containing allergen. The third, antibody binding to cell surface antigen is followed by complement-mediated lysis, shown on the left, or cell-mediated cytotoxicity, shown in the right part of the slide. It means complement-mediated cytotoxicity is a reaction of activation of complement system on the surface of the target cell. In the right figure, you see how antibodies bounded to the allegiance of the red blood cell, target cell, recognized by Fc receptor of the neutrophil, and neutrophil recognizes immunoglobulin G on this target cell as the opsonin, and the target cell become opsonized and very intensively engulfed. Third mechanism is killing is the antibody-dependent cellular cytotoxicity. When natural killer attacks the target cell, Y antibodies also, and destroy the cells. In some cases, cytotoxic hypersensitivity reaction type 2 is a result of the use of the drugs, some of them that may be bounded to the human cells. Bounded, and this cell or protein-associated form, these drugs may be converted to the from haptens to the complete antigen. And this form they stimulate antibody synthesis, and antibodies bind to the drugs absorbed to the red blood cells, or platelets or some other cells, activating complement system and causing attack of the natural killers, attack of the phagocytes. Here you see three possible situations that are associated with hypersensitivity reaction type 2. First, A on the top, opsonization and phagocytosis. You see that allergen contain target cell. Allergen is shown by the red ovals, where antibody contracts to the phagocyte. Phagocyte by Fc fragments binds antibody that before was bounded to the target cell. Phagocyte, due to this opsonization, engulfs target cell and destroys this cell. B, intermediate event, complement and Fc receptor mediated inflammation. On the surface of the target cell, allergens, also red balls, are present. Antibody may bind to them. Antibodies may react to the Fc receptors of the neutrophils and macrophages, and these activated macrophages may release cytocidal substances, for example, reactive oxygen species, destroying all the objects surrounding these neutrophils, including target cell. Of course, target cell may be damaged by complement system also, when complement will be by the classical pathway activated on the surface of cell, and cell will be destroyed. Situation C, marked by the letter C. This is a different situation that is characterized by antibody-mediated cellular dysfunction, not the lysis, but dysfunction. Here you see two examples of this dysfunction. On the left part of this C fragment of the figure, you see thyroid cell, or blue square thyroid cell, with them two receptors to thyroid stimulating hormone. If in the body of the patient appear antibodies specific to this receptor to thyroid stimulation hormone, bind of this antibody to these receptors may cause activation of signaling pathways that make this thyroid cell of production of increased amounts of thyroid hormones. It means this thyroid cell is not damaged, destroyed, but is made of production of the increased amount of thyroid hormones. And this thyroid hormone may cause symptoms of the disease. For example, increase of the body temperature. For example, loss of the body weight and some other. But cell is not killed in this situation. Cell is only stimulated. In the right part of this uh, figure, in the C line of these things, you see other disease that is named myasthenia gravis. You see nerve ending on the top that contracts to the muscle cell, forming synapses. Usually, if nerve impulse comes to this ending of the nerve, from the vesicles of the nerve, acetylcholine is released, and acetylcholine comes to the surface of the muscle cell, binds to the acetylcholine receptor, and causes contraction of muscle cell. In the myasthenia gravis, in patients are synthesized autoantibodies that specifically react to the acetylcholine receptors. And in this case, these receptors becomes broken and don't react to that acetylcholine. Result is the disease development that is clinically manifested by the lack of the left in the myasthenia gravis and in the right part when acetylcholine receptors bind to the antibodies shown blue, autoantibodies because they're synthesized against own structures. Acetylcholine receptors are destroyed and can bind acetylcholine and can transfer signal from nerve system to the muscle. This disease affects skeletal muscle of the limbs and those involved in the speech, swallowing, and movement. In this case, you see one of the typical symptoms of myasthenia gravis that is named ptosis. You see photographs and the drawing of the patients that can open eyelids because acetylcholine receptors are bounded to the antibodies and are neutralized. Hepatitis C type 2 may be associated to administration of many drugs. For example, penicillin, phenacetin, quinolone, methyl-dopa to the own molecules, antigenic molecules. For example, penicillin and phenacetin attach to red blood cells and induce synthesis of immunoglobulin G autoantibodies that will lyse these red blood cells, causing hemolytic anemia. The second drug, quinine, this is an anti-malaria drug, attached to platelets, causing formation of antibodies, antiplatelet immunoglobulins that cause thrombocytopenia, lowering of the concentration of thrombocytes. Other drugs, such as the hydrolyzine, the drug used to treat the hypertonia, well, this hydrolyzine may modify host tissues and induce synthesis of anti-DNA autoantibodies. Anti-DNA autoantibodies cause the symptoms of such the disease as the systemic lupus erythematosus. Systemic lupus erythematosus, this is a disease that may be caused by more than one present autoantibodies of the immunoglobulin A, immunoglobulin G, and immunoglobulin M against the desoxyribonucleic acid of the patient. In the black skin patients, typical depigmentation and inflammation is happening on the face, and this shape of this inflammatory zone of the skin rash resembles the wolf's mask. In the butterfly like inflamed zone. In the white skinned people, these places, the same places, develop the red color, inflamed zones, and you see also butterfly shape rash, but rash of the red color. Unfortunately, not only skin is affected by this autoimmune anti-DNA antibodies. Exception for skin, joints are affected, and kidneys. And patients may die due to development of the kidney failure. In some cases, the disease can be cured. The next hypersensitivity is type 3 immune complex hypersensitivity. This disease is found where mostly in the bloodstream long time circulate allergens. For example, they may be not only drugs, they may be antigens of pathogens. For example, with hepatitis B virus, in some patients with this disease, in the blood circulate very high concentration of the HBs antigen. This is a major virus antigen of this virus. So this long time circulation of the allergen in the blood causes initiation of synthesis of immunoglobulin G and immunoglobulins M against this substance. These immunoglobulins contact with the allergens in the blood, forming immune complexes. Here, see one of these complexes, gray, blue, purple antibodies, 3 and 4 molecules of the allergen. Of course, if they are so-called medium-sized immune complexes, consisting of hundreds of the molecules of the antigens and antibodies, these complexes may move in the bloodstream and in the organs where through the endothelial line very intensively filtration of blood is happening. Filtration of the liquid part of the blood from vessels to the in the kidneys, for example. This method is used by our organism to produce urine. In the joints, filtration of the liquid part of the blood from the blood vessels to the surface of the joint, causing appearance of the liquid in the joints. In the brain, also analogous process occur. In the skin also occur. What has happened? These mediate site immune complexes, due to the flow of the liquid from the laminar vessels between endothelial cells through the basal membrane to the submucous base membrane area, this flow of the liquid takes immune complexes and push these immune complexes in the space between neighboring endothelial cells. These complexes cannot pass through the basal membrane and are deposited on the surface of the endothelial cells. As immune complexes, they activate complement. Complement activation causes producing of the chemoattractants for neutrophils and macrophages. Macrophages, neutrophils, monocytes come to this area. They produce reoxygen species, some enzymes that are released from these immune cells and try to remove, digest, and destroy immune complex. But together with compensating immune complexes, neighboring endothelial cells also becomes destroyed. And later, not only cells of endothelium are broken, but basal membrane also. And from the vessel to the joints or skin or kidney, in the urine is transported not only liquid, but protein increased amounts. So after that, hemoglobin, after that, red blood cells. And hematuria is happening if we say about skin, about kidneys. So here you see immune complex disease development using example of the drawing of 3 elements of the vascular system. So, firstly, in the upper right part of this figure, you see how immune complexes are deposited on the surface of the endothelium. This deposition attracts to this area of the neutrophils and other immune cells. Neutrophils try to phagocytose immune complexes, release the toxic cytocidal compounds that cause segregation of platelets, destroying of the endothelial cells, destroying of the all the vessel of the all the wall of the vessel with the damaging, deep damaging of the vessel. Finally, rupture of the vessel. Results you see in the photographs in the right part of the slide. You see skin rashes that have what pathogenesis drawn in this figure. So normally the reticuloendothelial system can promptly remove immune complexes, but occasionally these immune complexes may persist and may be deposited in tissues, kidney, joint, skin. We talked about this. Lumpy deposits of immunoglobulin G and M and C3b components may be seen along basement membrane by immunofluorescence of the damaged organs. Lesions with similar lumpy deposits occur in an Artus reaction. This is one of the pathological reactions. Infective endocarditis, serum sickness disease, and such virus infections, such as hepatitis B and dengue fever infection. In this figure, you see development of the Artus reaction. Mr. Artus first described the skin reaction which can be induced in pre-sensitized people or animals by intradermal injection of antigen. Intense edema and hemorrhage develop 3 to 6 hours later this injection. What do you see here? Skin, subdermal yellow tissues, and the vessel, the low part of the drawing. If a region is injected, how is made by the Dr. Artus, to the subcutaneous tissue, agents cause coming to the series of antibodies from vessels. Antibodies from immune complexes. These complexes attract here from the vessels immune cells such as the neutrophils and macrophages. They try to digest these complexes, release wall of the vessel. Result is damaging of the vessel and reaction that is named Artus reaction. Analogous reaction may be developed in respiratory system. The farmer lung is known as the reaction where actinomycetes serve as the allergens, and their inhalation causes accumulation of allergens on the airways. Pneumonitis is developed, and these actinomycetes involved. Cheese workers' lungs, wheat millers' lung, woodworkers' lung, all these symptoms are associated to the inhalation of the microbes such as the bacteria and fungi by people who have occupational risk of developing this disease. Artus reaction at the side of anti-tetanus host serum immunoglobulins, if they are given at the same site with 2 short intervals, cause tissue necrosis also. But in the anti-tetanus host serum immunization, this disease was localized clinically, usually in the skin. Serum sickness disease. What is this? This is a classical disease based on the hepatitis C type 3. This is a systemic inflammatory response to the presence of immune complexes deposited in many sites of the body. After the single injection of large amount of the host antitoxic serum, animal serum, it can be recognized as the foreign antigen. This foreign antigen circulates in the blood, stimulates synthesis of an antibody, and 4 or 5 days after injection of the host antibody in the human organism appear anti-host immunoglobulins. Our antibody against these host antibodies. Antibody production starts and the simultaneous presence of antigen and antibody leads to the formation of immune complexes circulating in the blood. The complexes may circulate or be deposited at various sites. Symptoms appear a few days to 2 weeks after injection, and the antigen. What are the symptoms typical for this interval of time? Fever, urticaria, arthralgia, lymphadenopathy, this is swelling of the lymph nodes, splenomegaly, eosinophilia, eosinophils, of course. Symptoms subside when the antigen is eliminated by the immune system. It means one of the component of interaction disappears, antigen in this case. In this slide, you see in the upper part figure demonstration circulation in the human blood, different components of the serum sickness disease. Now, first of all, vertical axis demonstrates level of the substance, horizontal days. Initially, with this animal serum is injected to the patient. Presence of this antigen during 6 days stimulates synthesis of the antibodies, human antibody against animal antibodies. When human antibodies start circulating in the blood together with antigen, animal antibodies circulating in complexes are formed. Their presence is shown by the curve of the blue color. Red, this is antigen. Of course, antigen, after to the anti-antigen antibody, becomes eliminated. Complement activation, phagocytosis, and so on. And finally, by 10 to 12, disappears. But from 10 to 12 days, you see what this red square demonstration symptoms. Symptoms are skin rashes, damaging of the, not deep, but damaging of the kidneys with the appearance of the protein in the urine, vasculitis, skin rashes, and complement activation and cause some swelling and painful reaction of joints. But this is self-limiting disease because finally antigen disappears, becomes destroyed by immune system of patient, and the circulating immune complexes also disappear. Now here you see gamma ray photograph of the swollen and inflamed joints in the arms of the lady with rheumatoid arthritis. Rheumatoid arthritis, this is mostly a women disease associated to appearance in the blood of the patients of the so-called rheumatoid factor. Rheumatoid factor is the immunoglobulin M antibody, own human, against the Fc fragments of the normal human immunoglobulin G. It means that the blood of these patients appear antibody, immunoglobulin M, specific reacting to other type of the antibody, the form immunoglobulin G. And of course, in the joints, these complexes are deposited causing inflammation, that you see here. Glomerular nephritis may be a result of the chronic infection caused by Streptococcus pyogenes. These streptococci may generate synthesis of the autoantibodies that react not only to bacteria but react to their own epithelial and endothelial cells. Result, deposition of these immune complexes in the kidneys and glomerulonephritis as a result. And the last, hypersensitivity type 4, or delayed type hypersensitivity. What is happening? Pay attention to the figure. part of the figure marked by the A, sensitization phase of the reaction type 4. What do you see? You see the T helper cell recognizes antigen presented by macrophage or dendritic cell. This T cell, naive cell, is polarized. It means progeny of this polarized to the T helpers type 1. T helpers type 1 specific to this allergen, causing disease, circulating in the blood, and establish state of sensitization. After that, repeating inoculation of antigen is present. And the effector phase of the hypersensitivity is happened due to this. What is happening? Th1 cells, again, recognize allergen presented by the antigen presenting cell. But the result is releasing of the high amounts of the interleukin 2, pay attention of interferon gamma, tumor necrosis factor beta. Interferon gamma, other cytokines, interferon gamma hyperstimulate maturation of monocytes to the macrophages of the type 1, inflammatory macrophages. These macrophages are characterized by increased number of the MHC2 molecules on the surface, increased number of the receptors for tumor necrosis factor to the interferon gamma. Result of this is the hyperactivation of the oxygen burst in this case, hyperproduction by the cells of the reactive oxygen species, lytic enzymes of different origin, proteases, nucleases, lipases, and so on, and intensifying of the phagocytotic activity of these macrophages and release from these macrophages of the pro-inflammatory cytokines and lytic substances. The result, destroying of tissues, not only of the microbes that may consist of the allergen, but neighboring tissues, normal tissues of human organisms. But this process is delayed, and after repeat injection of allergen, all these cells must migrate to the infected area, accumulate in this area, and this process requires from 24 to 72 hours. Typical allergens causing hypersensitivity type 4 in the form of the contact dermatitis are the such substances are the cosmetics, nickel, poison ivy. Tuberculin reaction with the diagnostic test for tuberculosis is the hypersensitivity type 4 reaction is itself. If inflammatory reaction occurs too long time, granuloma formation may be happen in the infected area. Here you see stages of development of the hypersensitivity type 4 in the skin. Haptens, contact to the skin of the patient, engulfed by the dendritic cells, Langerhans cells that move to the lymphoid organs and present allergen to the lymphocytes. Lymphocytes show red and gray. Hyperactivated T cells from the lymph tissues migrate to the skin, causing inflammation. But at the same time, in the these tissues appear gray cells. Gray cells are down regulators of the inflammatory reaction. They are T-regulatory cells that try to prevent release of the pro-inflammatory substances from activating Th1 cells and macrophages. Tuberculin reaction diagnostic test, you see injection, dermal injection of tuberculin causes accumulation of inflammatory cells here. If are they present, if patient has these Th1 cells specific for allergen, cells will, these cells and macrophages accumulate in the subcutaneous tissues or in the skin, causing inflammation. Inflammation in the form of the red dot on the skin with infiltration of the skin and may be measured by the scale in the millimeters or centimeters, and diameter of this inflamed zone reflects intensiveness of the hypersensitivity for reaction. And final step: if allergen occurs in the tissues very long time, immune system patient try to localize this allergen, and to localize this allergen, granuloma may be formed. What do you see here? Macrophage engulf the Mycobacterium tuberculosis. This is a blue cell. But mycobacteria can replicate in the macrophages. Macrophages becomes activated. They produce cytokines and attractants that attract to this area immune cells of different origin. Dendritic cells, neutrophils shown orange, monocytes shown yellow. All these and T cells mostly accumulate in this area, forming infiltrate. Finally, in the walls of this infiltrate, fibrotic fibers are synthesized, and they surround this area, forming the shell. After that, calcium salts are sedimented to the shell, forming wall of the shell. Finally, with this last structure is named granuloma. Granuloma may be formed as the immune response for leprosy, histoplasmosis, cryptococcosis, coccidioidosis, and blastomycosis, and tuberculosis, of course. You see mycobacteria and a list of the fungi. What these fungi and mycobacteria maintain chronic inflammation with the formation of this structure that tries to encapsulate pathogens in the center. And in the center occur pathogen, and zone of the lytic cells is present. And in this slide you see three zones of the granuloma. Central zone shown green. These green cells are macrophages infected by pathogen, by mycobacteria, for example. Intermediate zone surrounds this central zone, shown by the blue cells. They are macrophages, activated M1 pro-inflammatory macrophages that form the structure that looks like epithelium. And due to this, these macrophages need epithelioid cells, but they are not epithelial cells, they are macrophages. And the periphery, you see peripheral zone, consisting of cells, immune cells of many varied types. T lymphocytes, B lymphocytes, what star-like dendritic cell, and elongated fibroblasts. But even fibroblasts are producers of this fibrotic encapsulation. And they produce collagen, they produce connective tissues, fibers. Finally, these fibers absorb calcium salts, and all the granuloma becomes calcificated, consisting of the wall that surrounds central part of the structure. This wall looks like the shell of the oyster. Finally, pathogen becomes localized in the center, and the wall of this granulome prevents spread of the pathogen to the neighboring tissues. Now, this is the last slide. Thank you for your attention. Goodbye, ladies and gentlemen.